memorizes the MRI scan, the venography, CT scan, and everyone forgets about the ocular investigations that you can perform. B-scan ultrasonography is a very underrated investigation in cases of papilledema. In fact, I suggest that can replace lumbar puncture. It has 80 to 90% sensitivity and specificity. This is not the sensitivity and specificity in pseudopapilledema. This is in papilledema. So, usually, you can diagnose papilledema by measuring the external diameter of the optic nerve sheath, ONSD. 3 millimeter behind the globe, which is this area, it would be enlarged. It would be 5.7 millimeter. It's normally 3 millimeter behind the globe and 1.5 millimeter the intraocular part. And in papilledema, it's 5 to 5.7. You need to perform an axial scan, not a transverse scan. You need to scan the nerve axially in order to get a precise measurement. The important issue is optic nerve sheath diameter does not normalize with short-term ICP fluctuation, so intracranial pressure might fluctuate. On performing lumbar puncture, you might take the opening pressure while there is a short-term fluctuation, so it might be normal. Lumbar puncture, LB, has very high sensitivity and specificity for ICP. But short-term fluctuations do not affect ONSD. As we mentioned previously, the optic nerve takes 5 days in case of increased intracranial pressure to swell. By the way, in few cases with intracranial aneurysm, papilledema could be reported in 1 hour, but this is not the usual. So the usual is 5 days, and you need another 5 days of reduced intracranial pressure for the swelling to resolve. The crescent sign, as you can see here, this part is normal during optic nerve head scanning by B-scan ultrasonography. But this crescent, this eccolucent area is not normal. This is very specific to increased intracranial pressure and swelling of the optic nerve, and this is related again to the ONSD. So if you see this crescent, this is very specific to high ICP. ONSD, if you measure it in 30-degree temporal position of the eye, temporal rotation, and compare your measurement to the primary position, there will be 10% reduction in diameter. So rather than being 5 in primary position, it would be 4.5 in 30-degree temporally. The last thing to perform is the C-scan ultrasonography. This is something fairly new in ophthalmology. So we have the A-scan, the B-scan, and the C-scan. C-scan is like the 3D ultrasound scan deployed in obs and gynae. So you take several scans of the optic nerve, and the software constructs a 3D en-face image, like the en-face OCT. So this is very specific, and it has implications in papilledema, to measure the optic nerve sheath diameter, and again it would be 5 to 5.7, and has other implications in optic nerve invasion with tumors, especially retinoblastoma. So this is important for your exam now. Retinoblastoma, Ellsworth stage 5. You can say, oh, I would like to perform C-scan, ultrasonography. The examiner might ask you, if you reach this stage, the examiner might ask you, you have two probes, the 12 megahertz and the 35 megahertz, the 12K, 12,000, and the 35,000. Which one would you use in papilledema and which one would you use in retinoblastoma? In fact, for papilledema, both can do the job. Although the 12,000 is slightly preferred for papilledema because it has better penetration. While 35K is best in retinoblastoma. It has lower penetration and it gives cross-sectional images of the intraocular optic nerve and shows higher resolution if there is any invasion in this area. MRI